Okay, so good morning, everyone. My name's Zach Quinnett from Imperial College London, and my co-chair is Professor Gleaver. HRS have really, the organising committee have really left the best for the end. We've got a fantastic session this morning with some top speakers. I'm looking forward to some very lively debate. We'd like you all to interact and please ask questions. So the first part of this session is we're going to have 4 speakers, and then we'll have questions, and then we'll have our exciting debate after that.
Yeah, so I want to just say welcome to everyone as well. We're really excited that you're all here with this energy that's been throughout this meeting on conduction system pacing and leadless devices. Is going to be great through this session with our wonderful presenters. You can ask questions using the app. They'll pop up on the iPad, but you're also welcome to please come to the microphone and ask questions that way. So we're going to get started, and I'm really excited to introduce Dr. Margaret Infeld from Tufts University, who's going to talk with us and teach us about Bachman's bundle pacing. Maggie.
Thank you so much. Thank you very much for having me. It's a topic I'm very excited about. Let's see if I can get it. No, start. So thanks so much for having me. I'm Maggie Infeld from Tufts. I'll be talking about Bachman bundle area pacing, why it matters, and how to target it. These are my disclosures. So in this talk, we'll review physiologic atrial activation, limitations of right atrial appendage pacing, positive clinical signals with Bachman area pacing, and then how to target it. So atrial conduction isn't random. It follows preferential pathways. Impulses travel more rapidly over parallel longitudinally arrayed fibers than in the transverse direction because of the density of gap junctions end to end. The sinus node happens to sit next to 2 key bundles that facilitate efficient biatrial conduction. The crista terminalis runs between the SVC and the IVC, and the Bachman bundle runs between the roof of the right and left atria. Together, these pathways support near simultaneous activation of both atria. Note their location very close to the sinus node, as opposed to the appendage, which is anterior and quite lateral. For decades, we've placed atrial leads in the appendage because it's reliable, but it comes with physiologic and hemodynamic trade-offs. This is the same patient paced at the same heart rate from 2 different locations. With appendage pacing, activation is sequential. First the right, then the left atria is activated, but with Bachman area pacing, biatrial activation is synchronized. And notice the difference in the paced P-wave morphology, which is really our global view of atrial activation. With appendage pacing, it looks quite abnormal, and with Bachman area pacing, it's normalized. And again, this is the same patient. We've known about the importance of the Bachman bundle in maintaining intraatrial and AV synchrony for over a century. This figure shows the relative timing of the right and left atrial contraction. With the Bachman bundle intact, the atria contract nearly simultaneously. However, when the Bachman bundle is damaged or activated late, the left atrium contracts much later than the right atrium. This can cause hemodynamic consequences, especially in patients with a stiff left ventricle or HFpEF physiology, as is the case in many of our older patients with indications for permanent pacing. When the left atrium contracts late, it's doing so against a higher LV pressure than when it contracts on time. This added pressure and stretch on the left atrium adds up when you consider that the heart beats over 100,000 times per day and 40 million times per year. With appendage pacing, we cause iatrogenic electromechanical delay, as shown by the bifid P wave and a delayed A wave on echo. With Bachman bundle pacing, the left atrium contracts earlier, resulting in very different hemodynamics. In the MyPace study, we found that patients with diastolic dysfunction or HFpEF and cardiac physiologic pacing in the ventricle had better outcomes when we paced them slightly faster than 60 beats per minute. This is a secondary analysis of the MyPace study, and we found that the benefit was greatest in those with Bachman bundle area pacing compared with appendage pacing. A third had Bachman pacing and 2/3 had appendage pacing. Based on landmark studies like the MOST and DAVID trials, we know that non-physiologic ventricular pacing increases the risk of heart failure and AFib. The ventricle doesn't like to be paced from abnormal locations. However, in the atrium, we continue to pace the appendage. This non-physiologic atrial activation is associated with increased AF in a way that scales with pacing burden and P-wave duration. Now, some of that may reflect underlying atrial disease. However, given the impact on left-sided filling pressures and atrial pressure and stretch, as we've discussed, maybe how we activate the atria also contributes. Dr. Balin from the University of Iowa performed the only multi-center randomized trial that's been published to date comparing these two approaches. Compared with appendage pacing, Bachman's bundle pacing showed improved freedom from AF progression. And importantly, this study noted the electrical response to pacing. Note the paced P wave with Bachman bundle pacing versus appendage pacing. This brings us to the P wave, which in our mind is the procedural endpoint of Bachman area pacing. Essentially, our goal is to maintain or restore normal atrial activation so that the paced P wave should look like a normal sinus P wave. It should have the same axis, leftward and inferior. It should be more symmetric and of higher amplitude, and often shorter duration. When we applied these P-wave criteria to 300 patients retrospectively, the signal becomes clear and results look similar to the study by Dr. Balin. Bachman area pacing improved freedom from AF and also AF burden over time. Prior RA septal pacing studies that didn't look at the paced P-wave were neutral. So it's not just where you place the lead that's important, the electrical response to pacing is really key. During implant, we often see these multi-component fractionated potentials. These are nonspecific, but they can be a helpful clue that we're in the right region because at the SVC-RA junction, multiple fiber bundles intersect, including the precaval band, which is the superior extension of the crista, and the Bachman bundle. And at the high RA septum, these fibers are oriented roughly perpendicular to each other, which can create anisotropic conduction and potentially explain the fractionated signals that we observe. However, more important than these fractionated signals, we think, is the paced P wave during mapping and the final result. When we applied this strategy of fluoroscopy mixed with electrical feedback, prospectively, we achieved P wave normalization in 87% of patients with Bachman area pacing and no patients with appendage pacing. We continue to observe this multi-component double potential in this region as well, and we're analyzing clinical outcomes. From a safety standpoint, we know the appendage is very thin, as shown in this transilluminated image, with wall thickness often less than a millimeter in certain places. The Bachman bundle lies in thicker septal tissue, so there's much less risk of perforation. And in terms of proximity to the aorta, which we're asked quite a lot, you'd have to really be quite anterior and screwing in very deep in order to go through this septal area into the aorta. In a large real-world cohort, Bachman bundle pacing was associated with a significantly lower risk of cardiac perforation and effusion, and other complications trended in the same direction. So at a minimum, Bachman area pacing appears safe and likely safer than appendage pacing. So how do we target this? The approach is simple, really. We use fluoroscopy to get into the region. Then we map for the electrical signal. If for nothing else, I do this to ensure that my P wave will be adequate for sensing. And then we confirm the electrical response with pace mapping the P wave. So it's really about combining fluoroscopic positioning with electrical feedback. From anatomic and mapping studies, we know that the RA endocardial insertion site of the Bachman bundle is reliably located between the fossa, the superior limbus of the fossa, and the SVC. And so getting to this area, we describe it as kind of a reverse transeptal under fluoro. So once the catheter and lead are in the mid-right atrium, we switch to an LAO view so that we're facing septal, and then we kind of drag the sheath up over the superior limbus of the fossa until it drops into that area of the SVC-RA junction. That's the general region. Now there's inter-individual variability in this RA endocardial insertion site of the Bachman, and we've seen this based on anatomic and mapping studies. And so we've tried to develop a way to target individual variability, and we do this by kind of flipping these images up caudal LAO, so you're kind of looking up the barrel of the SVC, and we say that we map between 2 o'clock and 5 o'clock if 12 o'clock is anterior and 6 o'clock is posterior. And just to kind of demonstrate this point, we don't use CARDO when we're placing the lead, of course, but just to kind of show you what we mean, we tip it up to look up the barrel of the SVC, and in this person, it was at 2 o'clock. This person, that green dot indicates it's at 3, and then this person, this red, indicates their Bachman insertion site, and it's kind of anywhere from 2 o'clock to 5 o'clock. So that's what we mean when we say between 2 o'clock and 5 o'clock. And this is using fluoroscopy to do that. So we already had our camera in LAO because we did that reverse transeptal maneuver. Now we put it at caudal about 30 or 40. And we use very gentle clock or counterclockwise torque on the sheath fin to map between 2 and 5 o'clock in this patient. Again, 2 o'clock is more anterior. I often find that the amplitude of the signals here aren't adequate for sensing, so I don't even mess around with that. I would be more likely to pace map here where, or at least in this patient, between 4 and 5 o'clock, because I know that I'll have adequate sensing there. It's a little like way to save time. And this is showing just slight movements, micro movements yields very different electrical potentials, and also different pace map P waves too. Notice here the sinus P wave is low amplitude and prolonged. When you pace at the site of this potential, it narrows, the axis is like normal sinus, and it becomes higher amplitude. And so one final point, this is really one of my favorite studies. Dr. Waldo from Case Western showed that decades ago, P-wave morphology really reflects when the Bachman bundle is activated within the inscription of the P-wave. So when the Bachman bundle is activated relatively early, the P-wave is normal, and of course there's exceptions, but and when the Bachman bundle is activated relatively late compared to the rest of the atria, the P-wave is abnormal. So just to drive home the point that the P-wave is our window into atrial activation, and that's why we think it's the most important endpoint for Bachman area pacing. So in conclusion, we've spent years optimizing ventricular pacing, but atrial activation also matters. It has real physiologic and clinical consequences, and we can improve it with a simple, reproducible approach. The P-wave is our endpoint. It isn't about perfect anatomy or targeting a perfect electrogram signal, at least as defined so far, but rather combining fluoroscopic positioning with electrical feedback. And what we need now is broader adoption so that we can do a pivotal trial. Thanks so much.
Thank you very much. We'll take questions at the end. Our next speaker I'd like to welcome is Dr. Rahul Doshi from SU School of Medicine, and he's going to tell us why atrial pacing, the option may be leadless.
Let's see here. Okay. So thank you very much, our esteemed panel, and thanks everyone for actually being here till the bitter end, right? The fact that you're all here is fantastic. And so it's my pleasure today to present a little bit about atrial pacing, or leadless atrial pacing, I should say. Here are my disclosures. Relevant disclosure for this talk is I'm on the steering committee and have been for the AVEIR ID trial, and now moving forward with leadless. So part of this discussion is that, okay, leadless pacing should be done in the AID. I don't really think I want to spend a lot of time making all the arguments why leadless pacing is important. You all are aware of the problem with leads, or the risks of using transvenous leads as compared to leadless, right? Whether it's anything with thoracic trauma, pneumohemothorax, or related to lead wear and tear, and certainly the chronic complications have been shown to be markedly less with leadless pacing. And it's interesting, as somebody who's been implanting transvenous systems for now decades, nobody thinks that they have complications with transvenous systems, yet we all have complications with transvenous systems. And they're not insignificant. This is from Medicare claims database that Dan Cantillon and I put together with some other folks, and 4.5% infection risk is not insignificant, a 3% risk of endocarditis, right? 8.2% lead revision, right? And then the 4% incidence of thoracic trauma. So these are not insignificant numbers. So obviously leadless pacing has changed at least that risk, or that or some of the complications associated with chronic wear and tear of leads, and then of course thoracic trauma. And these are of course landmark papers for both the original legacy nanostim device, which evolved into AVEIR, and the micro device. And there's been a whole host of literature now regarding leadless atrial-based, i.e. the DR system, right? There's the CIED trial for DR. We have demonstrated AV synchrony with these systems. We have demonstrated good electrical performance. We've demonstrated, again, AV synchrony and actual measurements. The communication between the devices is fantastic, fantastic. All this stuff, right? But they're all DR. So I'm here to tell you today that, well, despite all this data for DR, I think that actually, in somebody with intact AV conduction, AR is the way to go, and leadless pacing is actually bringing back the idea of single-chamber atrial-based pacing. So again, I don't need to remind anybody that the most common indication for pacing in general is sick-sinus syndrome, right? And that has not changed, right? So in somebody who needs sick-sinus syndrome pacing, it's atrial-based, right? And we know it has to be atrial-based, right? Because our classical studies have told us that atrial-based pacing is better than ventricular-based pacing in this patient population. And this, of course, is from the MOST trial and so many subsequent studies, right? So we know that there's an increase in heart failure and increase in atrial fibrillation when we have ventricular-based pacing in this patient population. But what drove this was the fact that this was atrial-based dual-chamber pacing in MOST, right? So again, it was atrial-based, and yes, demonstrated to be superior to ventricular-based pacing. But is there comparison data in the transvenous population for atrial only? And there is actually, and this was the DanPace trial. So again, another classical study that basically compared patients atrial only transvenous versus dual chamber transvenous. And what they demonstrated is that these patients did just the same from an efficacy standpoint. But the twofold, actually let me go back to this, right? The thing that drove the idea that we put in dual chamber transvenous systems was this simple statement: doubled the reoperation rate in the DanPace trial because of patients with sick-sinus syndrome progressing to AV block, right? So if you looked at the indications for upgrade, if you will, going from AAIR pacing to DDDR pacing, it was all AV block. So that need for reoperation that was double the rate in the atrial-only arm was the reason why the authors of DanPace actually recommended that in the sick-sinus syndrome population, we should be implanting dual-chamber systems because of the concern, of course, of actually re-intervening or basically reopening a previously created pocket. Okay, so my argument is that relevant for a leadless system? And I would argue that even based on DanPace, the complications associated or the risks associated with the reoperation are largely all removed if you're talking about a leadless pacemaker implant. The majority of these complications, if you see, whether it's myocardial perforation, again, thoracic trauma, et cetera, would all be avoided, or many would be avoided, in performing a leadless upgrade, if you will. And so this is one of my patients that actually was implanted with an AAIR system and then actually had a progressive need for ventricular-based pacing. And so this system, of course, is modular in the sense that you can upgrade in reverse. And so this patient who had an atrial-only pacing system was upgraded to a DR system. What is the likelihood of needing to do that, right? So here's a little bit more contemporary data. This is from 2018, that 92% of patients who received atrial-only pacing did not require an upgrade in the follow-up period of 10.4 years, okay? And more importantly, in fact, we think about, okay, what about an urgent need for upgrade? That only was the case in 2.4% of the patients. So a very small number actually need an urgent upgrade. And again, it's no different than those patients that you're implanting acutely for acute AV block, right? So no difference. The percentage of atrial-only pacing still remains low despite these data, right? So the majority of systems across the world are dual chamber. But is there data supporting atrial-only implants? And yes, there is. So this was Davy's study, Davy and Cyrus Haddad, who have actually been drivers of the leadless pacing world. And yes, there is good data that you can do atrial-only pacing with leadless. And here demonstrating not just good electricals as you'd expect, as we've seen in the CIED trial, but look at the procedure duration, right? They're very short implants, shorter than, of course, putting in 2 devices, and with very low complication rates, very low fluoroscopy, et cetera. Well, this also affects battery, right? So when you talk about an atrial-only leadless pacemaker, one of the problems we think about in DR is actually the differential battery drain and the decreased battery capacity with the atrial device, right? And this is, in fact, mitigated by eliminating that constant beat-to-beat communication, the eye-to-eye, right, between the two devices. And so when the AAI with VVI backup mode was made available with the Avera platform, this actually was tremendous at showing a demonstrated increase in battery longevity, being able to disconnect that coupling between the two devices on a beat-to-beat basis. And if you look at those longevities now, okay, if you're talking about an atrial device in a dual chamber system, the previous device, so I'll use the pointer here, let's say a typical pulse width of 0.4, depending on your pacing burden, this is your duration in years, right? So 8.3, 6.8, going down to 100% pacing at 3.9. Okay, so if you compare that with an independent mode of pacing, you see markedly increased battery longevity. Right, so you can imagine an advantage of going atrial only and not implanting a dual chamber system is a much longer battery. And now with the AR2 device, it's even that much longer, 25% longer. So what about the cost, right? So I would remind everybody that, at least in the US, as far as the reimbursement is concerned, it doesn't matter whether you're putting a dual chamber system or a single chamber system. The reimbursement actually ends up being the same. And so if you think about the approximate cost of the device, you know, a ventricular device is about $9,000, an atrial device is about $13,000 plus a delivery catheter. Well, that's what you're spending, obviously, in doing the implant. So if you're putting an atrial only, it is much more cost effective for your institution. So I'd conclude that the vast majority of patients with sick sinus syndrome only need atrial pacing long term, and that's been demonstrated. The dual chamber pacing platform is modular. So why not give the patient only what they need, and if they then develop an additional indication, you can upgrade later without the same risk of going back into a pocket, and that's the advantage of a leadless system. Less device implants in general, of course, decrease the likelihood of complications, and atrial-only pacing maximizes the longevity of that implant. And atrial-only pacing is definitely much more cost-effective. And I just want to make one comment, actually, that sort of piggybacks on the last presentation. As it's been described, as you all are aware, you can do atrial leadless pacing in Bachman's bundle, of course, right? So you can actually do atrial physiologic leadless pacing, and that's been well demonstrated now. So with that, I'll go ahead and conclude, and thank you very much for your attention.
Outstanding. All right, well, it's my distinct pleasure to welcome Dr. Jackie Joza from McGill University, who's going to teach us all about conduction system pacing, which is a hot topic. So, Jackie.
Thank you very much to the organizers and to the chairpersons here for the opportunity to present. Okay, why conduction system pacing is the preferred approach. Here are 3 reasons. Synchrony matters. Leadless devices do not capture the conduction system, even if they say they do. Data favors conduction system pacing. And 3, transvenous lead complications are lower than what we are made to believe. So synchrony. Synchrony is the natural order that arises out of chaos, and there's a mathematical model that explains why this is actually happening. Here you can see metronomes naturally will fall into sync through weak coupling. Dots will gradually approach each other, and even seemingly random, these fireflies will eventually start to fire in unison. So we see synchrony throughout nature. And in fact, restoring natural synchronized electrical conduction then should be the goal. So let's look at this intrinsic rhythm ECG, and we have mapped the right and the left ventricles here. This is intrinsic rhythm. Watch where the early activation appears. It appears here in the RV apex, LV apex, and the moderator band. That's a normal atrial activation. So apical, moderator band, and then out to the lateral walls of the right and left ventricle. And now let's look at a proximal left bundle branch pacing implant. Here at pacing at just above threshold, so we're looking at selective pacing here. And you can see a very similar, very normal synchronous nature. So early activation, again at the RV and the LV, earliest on the LV because we are selective here, and then extending out. So we've maintained synchrony with even left bundle branch pacing. What about non-selective pacing? Well, even more so. You can see here early activation on the right and the left ventricular septal, and then again proceeding out. So really beautiful, beautiful map showing that we can really mimic synchrony. I won't show the RV pacing one. But you can also see that even to your naked eye, you can see on these echo images, sinus rhythm here and left bundle branch pacing here. I can't really tell the difference here with regards to the ejection fraction. So very, very similar. Strain is another way to look at this. We can see here with non-selective, selectives, and selective His bundle pacing here, you can see these very normal type of strain or shortening or contraction type patterns, whereas that's the synchronous type of activation can be seen with right ventricular apical pacing, where you see in red the septal bounce that corresponds to the same time that you're trying to activate the lateral wall. So very desynchronous, even looking at the strain on echo. And in contrast, of course, RV pacing causes dysynchrony even when you look at ultra-high frequency ECG, another way to look at synchrony, where V1 to V4 represents the right ventricular activation and V5 to V8, the left ventricular activation. You can see very delayed RV and LV lateral walls. And if you try and think that you can put this lead in the RV OT or maybe a little higher in the septum, think again, you still have now earlier activation in the right ventricle, followed by delayed activation in the left ventricle. And finally, we know that dysynchrony leads to pacing-induced cardiomyopathy, and although many of these numbers may be overinflated because they are observational in nature, still, if you take a a cutoff of ejection fraction below 40% to define pacing-induced cardiomyopathy, you still result in 1 in 10 patients developing pacing-induced cardiomyopathy. Okay, so 2, the data favors conduction system pacing. So the leadless crowd will tell you, well, pacing-induced cardiomyopathy doesn't exist in leadless pacing, and they cite 2 usual papers. They cite this retrospective review of pacemaker-dependent patients with leadless or transvenous post-AV node ablation, and they followed them for incidence of pacing-induced cardiomyopathy, again, retrospective, and 13% of transvenous versus 3% of leadless developed pacing-induced cardiomyopathy. I mean, I don't understand how that can be possible. You're still putting this lead on the RV septum. And then further, another retrospective database looked again and found that if you put it at the apex, it was much worse than putting it at the septum, at least the leadless device. But the QRS durations were very similar, 166 versus 168 milliseconds. So how can that possibly be true? And so the data continues. So we see that actually when you match the groups properly with propensity score matching here, you can see that the rates of pacing-induced cardiomyopathy are no different. And in fact, the usual predictors will come out. It's lower pre-implant ejection fraction and wider QRS, so mostly above 150 milliseconds. And finally, the nail in the coffin for this data, conduction system pacing versus leadless versus transvenous RV pacing. Retrospective inclusion of patients undergoing single-chamber pacemakers, leadless, RV pacing, or CSP at either Geisinger or Beth Israel. And they matched with propensity score matching. These are the baseline characteristics. I just want to point out they're all similar except for the fact that, of course, pace QRS is much narrower with conduction system pacing, and in fact, conduction system pacing had higher ventricular pacing proportion. What you see is conduction system pacing produced a 30% relative risk reduction in primary outcome of death or heart failure hospitalization, and if you looked only at if they were paced more than 40%, you had a significantly even more relative risk reduction with conduction system pacing versus leadless, whereas leadless and RV pacing were quite similar. And finally, Milos Reloaded, beautiful prospective data showing mortality benefit with left bundle branch pacing versus RV pacing, again, though observational. And this large prospective database from the Chinese group that came out in JACC EP just this month, showing, again, very similar type of data. So 3, the risk of complications is lower than what we are made to believe. So again, these are often cited by the leadless crowd. High rates of complications with transvenous pacing. But these are relatively old, retrospective type of data. And when we look at more modern type of data, prospective or early or more modern retrospective, those numbers have come significantly down. So I don't think that's necessarily the best argument to proceed with leadless pacing. And finally, device-related tricuspid regurgitation, I believe, is primarily related to dysynchrony, and more we're understanding that this is the case. This is a retrospective study looking at tricuspid regurgitation in leadless devices. Worsening tricuspid regurg was found in 43% of patients with micro and aneurysm. And of course, the key predictors are the ones that cause dysynchrony. So if you add a RV lead creating dysynchrony to already present left-sided disease, well, you're going to create even more dysynchrony and more tricuspid regurgitation. And of course, the tricuspid regurgitation is even worse if you have baseline RV dysfunction. So this is, I think, very important data, and it really challenges this prevailing belief that leadless pacing avoids tricuspid regurgitation. And so in conclusion, synchrony is a natural phenomenon. Nature prefers synchrony. We seek synchrony in nature. Strong observational data is suggesting benefit of synchronous pacing over RV pacing. Leadless pacing causes pacing-induced cardiomyopathy to a similar degree as transvenous, and complication rates are lower than presented. And importantly, we are awaiting 3 large RCTs of transvenous versus left bundle branch pacing to show the true rate of pacing-induced cardiomyopathy in the bradycardia patient, and that is PROTECT-HF by my colleague here, Zach Winnett, our trial, LEFT-HF, and LEAP, which should be available by the end of this year or next. Thank you very much.
Thank you, Jacqueline. And now it's my great pleasure to introduce Dr. Judith McCall from the University Hospitals Cleveland Medical Center. And we're going to have the counter view. Leadless pacing is safer, simpler, and smarter.
Thank you, Drs. Winnett and Gliva, colleagues. I'm delighted to be here today. I'm a fan of all pacing. But today, I'm going to tell you why I'm a fan of leadless pacing. And I've been charged with talking about, is it simpler, is it safer, and is it smarter? And I will attempt to do that in the next 10 minutes. So when we talk about leadless ventricular pacing, we're comparing it to traditional transvenous ventricular pacing. We have 2 FDA-approved leadless pacemakers on the market. The Medtronic Micra came on the market in 2016, and the Abbott Avere VR came on the market in 2022, and the Avere DR in 2023. These are self-contained miniaturized pacemakers. They're implanted in the right ventricle, usually during a femoral access, via a femoral access approach. For those of us who implant, we recognize the sheath is large, 23 French interlumen, and they have different fixation mechanisms, which is probably relevant at least to some of the potential complications of the leadless devices. The Medtronic Micra has the nitinol tines, which mimic passive fixation, and then the Avere has the fixed helix with steroid-eluting and mapping abilities during implant. Neither of them can store an electrogram. Both of them are MRI conditional. When we think about complications and we talk about the procedural complications and we look at the IDE trials and then the longer follow-up in the post-approval registry and the coverage with evidence development trials, we note a few things. One, all of those complications related to transvenous devices, pneumothorax, lead dislodgement, lead infection, pocket hematoma, they're all gone. This is nothing that we see with this implant. But we replaced it with vascular complications and then pericardial effusion. Initially, the perforation and pericardial effusion rates were higher, and at the beginning, recall that we were targeting the RV apex, and then with movement of that to the apical septum, we saw those rates come down. Now, we do know, again, we can argue what is the true rate of pacemaker complication, but many of our colleagues send us a patient and say, oh, just put a pacemaker in. That's a low-risk, routine procedure. And I think we know, if you take a hard look, that any invasive procedure carries complications. And transvenous pacemakers, yes, they do carry complications that are easily handled as compared to the pericardial effusion complication that we sometimes see with leadless. But if we look at then the longer-term follow-up in that first 6 months and first 12 months, the hazard ratio for complications is significantly lower for leadless devices, 22 to 30% lower. So I think this is significant and equivalent between leadless devices. Recall transvenous leads long-term are problematic. They don't last forever. And when they're associated with lead-related infections requiring extractions, and sometimes multiple extractions, we really are exposing our patients to, I think, high risk and high mortality. Just to think for a minute about the pericardial effusion and cardiac perforation risk, this was a nice summary trying to suggest that in the contemporary studies now, they're pretty equivalent. Well, they're not really totally equivalent, because we did see a marker that if you have a pericardial effusion or a cardiac perforation, you are more likely to need surgical intervention, and the mortality associated with that approached 30%. So both devices recommend that the implant be done by a trained operator in a center that has surgical backup, or at least has a defined rapid response arrangement in place, because when it happens, it is a big deal. So now moving on to whether these leadless devices are smarter. Well, they both purport to have great battery longevity, and in the single chamber modes, I think with a good threshold, it's wonderful to see battery projections that are in the teens. And I think they both do that. And so from a need for frequent device replacements, this is a smart choice. Let's talk about some of the smart features they have. One of the ways that the Avere device gets its battery longevity so long is that it uses something called conductive communication. That markedly decreases the pull on the battery compared to RF or Bluetooth. And we know that the Avere, as we heard from Dr. Doshi, can provide, when coupled with an atrial leadless device, dual chamber pacing. However, when you use that synchrony, you do affect the battery longevity. Now, the second generation is a little bit better because it has a little more battery, but you're not going to see those long 15, 16, 23 years when you start using eye-to-eye communication. And so to combat that, we have a new programming option in the leadless devices, the AAIR plus VVI for backup for those sinus node dysfunction patients. Why is this a wonderful option for patients who conduct? Because it then shoots that battery longevity out to where we'd like to see it. So that's a smart feature, a smart programming option. The Avere VR and AR also have a novel rate response sensor. So I don't know how many of us think about how rate response works, but in the Avere, they have a thermal sensor that's inside the device, and it's every 5 seconds, it's reading the temperature of the central venous temperature. And it has a long-term rolling average and then the short-term rolling average, and it will adjust the sensor to what it perceives that difference is. So when you start exercising and you move all that cool blood in from the periphery, the central venous temperature drops, and then as you exercise, it starts to go back up, and the sensor is responding to that change in temperature. And What's cool about this is that it can, because central venous temperature also changes during periods of emotional stress, circadian variability, and ambient temperature change, it actually may give us a physiologic sensor that we haven't seen. So that, I think, is potentially a smart feature. Now, the Medtronic Micra also has a novel sensor, and I think we have a lot more experience with this in clinical practice, because there are now many more Micras out in the world, actually approaching 250,000. Micra uses this novel 3-axis accelerometer, and in a head-to-head comparison, it's comparable to VVIR in the transvenous pacemakers, but it also is capable of detecting atrial contraction, and so it can sense atrial contraction, which on this diagram is the A4 spike, and then trigger ventricular pacing. So you have the option with a ventricular leadless device of tracking atrial activity and providing AV synchrony with a single device in someone who has intact sinus node function. Now, it can only do one or the other, it can't do both. So it doesn't mode switch for atrial fibrillation. So if you are VDD, you are not going to have the rate response on, and if you're VVIR, then you can have the rate response on. The upper tracking rate in the second generation was increased to 135, which is, of course, a good thing. We did see with the first generation that there was interesting loss of AV synchrony at higher heart rates, but also with positional changes of the patient. So you're in the lab, you put it in, it's looking great, the patient stands up and walks, and then it's not looking so great. So they have another smart feature, a smart programming option called the activity mode switch. The activity mode switch, again, not a mode switch for AFib, but it is looking at the sensor rate, and then it's looking at what is the V-paced rate, and if it drops too low because it's lost AV synchrony, which is usually with exercise, it will come on VVIR to at least give you heart rate response when you lose AV synchrony at higher heart rates. So that, I think, is a cool thing, obviously opinion. So 11 electrophysiologists got together in Europe to put out a statement on how you should program the Micra AV2 to promote AV synchrony. They suggested that you make sure that you actually can sense atrial contraction before the implant, and that the surrogate for that is the E to A assessment, which if it's greater than 1.5 actually suggests that you may lose AV synchrony. And then they suggest that you turn on that novel feature we talked about, the activity mode switch, because that will help give you heart rate response with exercise, and then to set the lower rate down to 50. So this is my slide also that says, reinforces, is this really simpler? Well, I think if it takes 11 electrophysiologists in the room to decide how to program something, it's probably not simpler. All of these smart features require smart EPs. We need to know how to program to optimize synchrony. We need to recognize that there can be positional changes during implant and afterwards. We might lose AV synchrony at faster heart rates with the Micra, so we want to make sure that activity mode switch is on. And the loss of AV synchrony does have some ramifications. Primarily, let's not forget pacemaker syndrome, which does occur. There is an increased risk of AFib when you use VVI pacing in the presence of intact sinus node, and as well as exercise intolerance. When you use the AVEIR dual chamber, you do impact the battery longevity. Position of the devices to each other impacts on the communication, but almost all of them can achieve excellent AV synchrony. And then we end up with both devices, two devices reaching elective replacement at different times. This is just a slide to say we also have to be smart about patient selection. Good choices we know are those that have limited vascular access, who are at high risk of infection because there is almost no infection with these leadless devices. End-stage renal disease patients, the dialysis patients we feel are at higher risk of infection. And those who have AFib with bradycardia who really need VVR pacing, I think this is really a great option. And in the presence of a bioprosthetic tricuspid valve, a little more challenging perhaps, but again, it does give you the option of not having a lead across the valve. I don't want to spend a lot of time talking about situations where you might use a leadless ventricular device tracking off previous atrial pacing lead that still works, because there are options out there to use your leadless ventricular device with atrial devices. We now have the ability to place these devices via IJ access, and so that kind of takes the IVC filter off the table as a avoidance. I do want to say that heart failure is always a concern, and if the patient is indicated for CSP or CRT, this is not the device. And if you're planning an open cardiac procedure, if the patient's going to be undergoing surgery, you probably don't want to put this in. It's still a little bit unclear to me in young patients, even though I find it very attractive not to saddle a young patient with a lead. I'm not sure what planning replacements and additional leadless devices, a lifetime of leadless devices, I'm not sure what that looks like yet. This was data that was published recently from France, a multi-center trial of close to 6,000 micro patients. These are first generation. I really think what's relevant is that the need for revision of the system after implant is very low. And why you end up revising: heart failure, pacemaker syndrome, and then high thresholds, which are unacceptable. So 3 things that I think are relevant to using leadless devices. So I think I would like to say that these devices are not simpler. Novel sensors, novel communication, new programming, modes and algorithms, patient selection maybe not always clear. Are they safer? I do think that the data favors leadless devices from a safety standpoint. Are they smarter? Well, I'm going to say maybe. I think for some patients it's a very smart choice, but again, those limitations with regard to synchrony and heart failure. Now, looking to the future, we were all excited to see the first human leadless CSP was presented actually last year, and then again Saturday, some additional data. So there is this idea that we'll be able to do that with a leadless device. And then we also saw from Medtronic, this was from HRS in 2025, but they also presented now successful implants in humans, that a single device implanted in the triangle of Koch and drilled into the septum can capture the LV and can pace the back end in the RA, sensing and pacing with one device. So very exciting times for leadless pacing. Thank you.
Thank you very much. We're running a little bit short on time, but we've got lots and lots of questions coming in. First quick question for Dr. Infeld. You say you use P-wave morphology, P-wave duration for confirming capture. Can you tell us a little, do you think that's enough? Can you tell us how you run that through? Do we need other measures like output-dependent transition and things, or you think, talk us through your workflow?
Yeah, so I think we're still developing some of these ideas, and I think we should be actively investigating. Like Ed Cronin had a really nice example from a heart rhythm case report where he demonstrated that he lost that fractionated potential with lower output, and then there was intra-atrial block, and I thought that was a really nice example. I think that we could do better than the appendage, and so in terms of I think from Dr. Waldo's study, if you have a healthy atrium, you might not need to be right at the area where the precaval bundle and the Bachman bundle intersect. But again, if these patients are going to have these leads their whole life, like if they are going to develop fibrosis or myopathy later, it's probably better to be as close as possible to that area.
So still developing criteria for definite confirmation, but you think there's a little bit of leeway in terms of where we put the lead, as long as we're close-ish to the area.
I mean, I think, we have to be practical a little bit, like we're all getting pressured to do cases fast, but we always want to do the right thing for the patient and give them the best result. But I think that we're going to do much better if we place it near the Bachman bundle than in the appendage. So I think, it's just being practical about things.
Right.
Okay, so here's another question that maybe we can go to one of our leadless folks. The question is, role of upgrade from VDD or micro AV to AV device to dual chamber pacemaker. So Judy, you showed us that data that isn't very frequent, but practically, do you see that? Have you done that?
I have not done it, well, I have done it, but not in that way. So we had a patient with lead fracture who was dependent and was refusing lead extraction, and so got a micro VR. Now this is someone with supposedly intact sinus node who wasn't atrial pacing very often. And so it was a ventricular lead fracture, the patient got a micro AV, and then had pacemaker syndrome because really was not able to track. And actually a little bit of both, a little bit of rate response then, but by putting the atrial device back on, using the pacemaker as an atrial pacer and pacing higher, like we increased to 70, and then the micro was able to sense. So there are innovative ways to regain synchrony, but I think the removal of the micro chronically is difficult, but that data from France that I showed, their mean time for upgrade was 80 days, and they were actually proposing that you should remove them more often because they're very easy to take out and there were no complications. So we shouldn't be afraid to upgrade when we need to do that, especially in the first 90 days. There's data.
So that brings us to another question from the Leadless about removing devices. So we're saying lead-related complications when you're doing lead extraction, worst case around sort of 2%. Firstly, is there data regarding safety of extraction of leadless devices? Secondly, my own question is, these devices have a bigger footprint. We're targeting specific areas in terms of the conduction system. You mentioned atrial, targeting the Bachman's bundle. Do you have concerns about then needing to when we then need to reimplant devices, whether we've burnt our target, or what do you think? So firstly, safety of extraction. Secondly,
Right. So regarding the extraction experience, right? So there have been again, differences between the two devices, right? So anything we talk about with micro or the tine fixation is off-label. Having said that, there's actually a growing amount of experience about safely removing these devices, and to me, the idea of just putting one device on top of another device doesn't make sense. Hence, the demonstration of the helical fixation proof of concept is that these devices can be safely removed, right? So the most recent series approaches 90% success rate that Peter presented. He has taken out a 9-year-old device. I've taken out a 9-year-old device. And the reality is the implant, and we actually just presented this yesterday. What am I saying? This morning, actually. That tells you that from the ID trial, that the retrieval experience or the procedural duration has no correlation with the duration of the device, right? So proof of concept, when you have an active fixation, if you unscrew it, you can remove it regardless of the duration. So the key thing here is that accessing the proximity or accessing the docking button, right? That's what correlates with the retrieval success. If you can access the button, you can retrieve the device in every case. And that's been well demonstrated. Having said that, there is obviously limited experience with the atrium. But thus far, the atrial device that have been replaced, and it's only a small number of patients, and up to about 2.5 years, they have been universally successful and safe. That you can absolutely replace or remove an atrial device as well. And then your question related to, are we using up targets? I think we have plenty of real estate in the ventricle, and obviously we'll learn in the future, hopefully the very near future, if there's any differences with physiologic when we get to physiologic leadless. But as regarding the atrium and Bachman's bundle pacing, it's interesting. You know, obviously Bachman's bundle is a very defined area, right? But as you mentioned, it all has to do with degrees of anisotropy, right? So if you are implanting in an area that has longitudinal fibers into Bachman's, you're going to have a very short P wave duration, and that's actually over a relatively large area, right? So that's demonstrated whether it's true Bachman's, arcuate ridge, on the septum, septal side of the appendage, you all have those longitudinal fibers that are going into Bachman's. And so you can have very comparable P wave durations if you pace in any of these locations. So I think what's going to happen is that we're going to find that we can get to this in at least in healthy atria in many different ways. And it does relate to the fact that, you know, I think if you look at the majority of implants of the atrial leadless pacemaker, the majority of them on the lateral side of the appendage. And that was initially done to perhaps have both devices kind of oriented toward each other to minimize or to decrease the eye to eye. Well, it turns out that that distance or that vector is not as important as just simply the distance. And so being on the medial side of the appendage, you can actually get short P wave durations and much better eye to eye, actually. So that also drives better battery life. So
You're the Krista there.
absolutely, absolutely.
Okay, so we really are running short of time, but Jacqueline, one very quick question. The theory is great. We're all so more physiological activation is great, but obviously in clinical practice we're seeing big variations in what people are actually delivering. How do we? What do we need to do to make sure we're getting consistent outputs of our conduction system attempts?
This is one of the most important things, actually, is you hit the kind of the problem, because everybody thinks that they know how to do left bundle branch pacing when even I've been doing it for so long now, and I find like I don't always achieve left bundle branch pacing, and we have to understand, if you don't understand the criteria, you don't know when you haven't actually reached left bundle branch pacing. You know, so I think an in-depth understanding is necessary, and I think what I found very helpful also was to go around to other labs. There are programs that the Medtronic puts on, for example, where you can go and watch kind of expert implanters and learn new tricks, and I think that that's essential because the definitions of left bundle branch pacing are muddied, and I think we kind of need to set the course straight again.
Great. Yeah, thanks very much. And that leads us on perfectly to the second part of the session, which is a big debate. So thanks very much to our speakers, and if we can have the two next speakers come up to the stage. So this is the debate where we're going to hear the pros and cons of adopting a conduction system pacing approach.
All right, so as our debaters come up, I really want to thank our panel of experts. You guys are clearly leaders in the field, and we appreciate your insight, contributions, and fantastic presentation. So thank you so much.
Okay, so with that setup, we are very, very fortunate to have a left bundle branch area pacing debate. And our first presenter is Dr. Lau from Royal Victoria Hospital, who's going to say, is this overused and oversold? Both? Neither?
Right. So good afternoon. Is left bundle branch block area pacing, or LBAP, overused and oversold? It all depends on the benefit-risk balance. Now, this is the outline of my presentation. I will first talk about some general principles of risk management and apply them to the execution, complications, and benefits of LBAP. So first, risk management. What is risk? In common parlance, risk means danger and adverse outcome, which could be a loss or missing out on a gain, a complication or harm from a treatment. But risk could also mean uncertainty relating to recognized outcomes or unrecognized outcomes. Adverse outcomes are measured by their magnitude, and uncertainty is measured by probability. Risk assessments is generally performed by multiplying the magnitude and probability of adverse outcomes and then grading them according to their products. Now, this formula assumes that the probability of and magnitude of adverse outcomes are independent, but they could actually mutually influence in subjective representation because of cognitive biases. Loss aversion means a loss hurts more than a gain of the same size pleases. So for loss aversion, only the magnitude, but not the probability, matters. It has been estimated that a gain has to be at least twice as large as the loss to be equivalent. For LBAP, the maximum gain is mitigation and avoidance of pacing of lamp-bundle branch block-induced cardiomyopathy, which is seldom fatal, whereas some of the LBAP-specific complications could be. So by loss aversion, the patient would not choose LBAP. One should never turn a non-fatal condition into a fatal complication, a fatal operation, because no one is going to thank you for that, including yourself. Risk aversion means a smaller certain gain is preferred to a larger probable gain. A bird in hand is worth two in the bush. For risk aversion, probability matters more than magnitude. So if we take 100 LBAP patients, 15 of them will receive futile iatrogenic harm from LBAP-specific complications without deriving any benefits because of a failed procedure. And 26 patients will receive definite iatrogenic harm and possible benefits from left ventricular septal pacing. And 59 patients will receive definite iatrogenic harm and probable benefits from conduction system pacing. So for a risk-averse patient, he or she may prefer the certainty of right ventricular or biventricular pacing to the uncertainties of LBAP, even if LBAPs could deliver far more superior clinical outcomes in the best-case scenario. Now, people tend to inflate the chance of rare events and discount the chance of common events. For a treatment to be approved, complications must be rare and benefits common. So patients may tend to view the complications to be more common and benefit less common with LBAP than they truly are. Now, for LBAP to be recommended, its expected benefits must exceed its expected risk. The advocate will say that LBAP is safe for patients because serious complications are rare. The lawyers would say LBAP is unsafe for the providers because serious complications are rare. Providers are far more likely to be investigated, complained about, and sued for rare complications than common ones. And there have been clear precedents of this resulting in successful criminal convictions. So let this sink in for a while. Okay, this concludes my section on risk management. I'm going to talk about the execution of LBAP. I'm going to talk about choosing the target site, moving to the target site, seeking the intended target, avoiding the intended targets, and finally, reaching the target. Now, choosing the target site is mainly by fluoroscopic anatomy, not electrophysiological mapping. It's generally recommended to aim for about 1 to 2 centimeters from the His bundle potential position. But what exactly is this 1 to 2 centimeters? The length of an object in the fluoroscopic image could change because of rotation, lateral movement, or movement towards the image detector. So for the fluoroscopic length to be a reliable, consistent surrogate measure of anatomical length, not only does the angle of the imaging arm, but also the lateral position of the table and the height of the table will need to be standardized. But even with all this standardization in imaging, we could not account for rotation, anatomical variants such as rotation of the heart inside the patient's chest and kyphoscoliosis. So the alternative is to have some form of grid system to partition the fluoroscopic image of the heart in the RAO projection. The target site will be roughly 1/3 the distance between the tricuspid annulus and the right ventricular apex. But for the two systems to be consistent with one another, you have to assume that the patient's heart is about 6 centimeters in length in the RAO projection. But what if the patient's very tall, very short, has a dilated heart from dilated cardiomyopathy or LV apical aneurysm? So the whole thing falls apart. Okay, moving to the target site. So manufacturers produced a plethora of delivery catheters. But the delivery catheters effectively go wherever they want to go, and the operators limited control over where they want to go. You could shape them to a little bit, but still limited control. So the manufacturers actually choose the target site for the operator. Manufacturers can only produce a finite number of catheters, whereas the variation in human anatomy is infinite. A diffractable catheter has a larger reachable zone, but even they could not reach the basal-cranial interventricular septum easily, and that's where you need to go for left bundle branch or hip bundle pacing. Okay, setting the intended target, by which I mean the left bundle branch and the vesicle, they cover only about 11.5% of the left bundle branch area. So the chance of you hitting them by blindly stepping at the interventricular septum from the right ventricle side is actually quite low. This is especially so because the basal cranial interventricular septum, where the conduction system is most concentrated, is also the hardest for the delivery catheter to reach. Avoiding the unintended targets, by which I mean the septal arteries and the veins, that very evenly and densely distributed throughout the interventricular septum. I don't think it's actually possible for you to miss them, even if you try your hardest. And the reason why septal arterial fistula or hematoma has not been seen more commonly with RV pacing is because the spiral track created by the fixation helix is only about 2.25% in cross-sectional area and 125% longer than the cylindrical defect created by the tip of a 6-French lead. And that creates a 56 times higher resistance to blood flow. Okay, finally, reaching the target. Between 0.8 to 5% fixation helix are damaged during attempts to penetrate the full thickness of the interventricular septum. And sometimes the lead tip could fragment inside during the procedure, resulting in a fragment being retained inside the patient's body. But even with all this effort, the fixation helix may fail to reach the left ventricle, the intended target, in about 15 to 20% of cases, resulting in deep septal pacing or left ventricular septal pacing. Okay, this concludes the session on the execution of LBAP. I'm going to talk about the complications. And this table lists all the recognized LBAP-specific complications. I'm going to concentrate on a few key ones. Now, right and left bundle branch block and complete heart block has only been observed with deliberate attempt at left bundle branch pacing. And that may have something to do with the fact that the first septal artery supplies the hip bundle and both bundle branches. It's very vulnerable to damage when the fixation helix is penetrating the basal cranial interventricular septum. So the most physiological form of left bundle branch pacing, of LBAP, aimed at protecting the patients from pacing-induced cardiomyopathy could paradoxically make the patient more vulnerable by inducing heart block and increasing the pacing burden. And the second is septal hematoma. This occurs about within hours to days after LBAP. Now, generally speaking, it's quite well tolerated and tend to be self-resolved, but on occasion, that could be life-threatening. And that's the worst-case scenario for any interventional cardiologist, when a simple routine low-risk procedure turns into one well complicated by life-threatening complication, requiring emergency complex procedure to treat. I'm talking about what I talked about earlier on. Now, most of the time, it's remarkable that the interventricular septum could blow up to 4 to 5 times its normal size without rupturing. But definitely, there would have been a myocardial infarction because there's always a troponin T rise. And there will also have been extensive structural damage, disruption of the mechanical integrity of the interventricular septum. And sometimes you could see a dissection or cavity within the interventricular septum, enough to cause ventricular tachycardia at times. Now, generally speaking, there has been reported this interventricular septal hematoma will resolve over time within weeks to months with complete return to normality. But I think there's an illusion. I think the void created by the resorbed blood will be filled with fibrous tissue, and that could adversely impact the contractility, erythrogenicity, and also the ease with which leads could be implanted and explanted in the future. And I've talked already about fixation helix damage. I think the 0.825% quoted rate of intraoperative fixation helix damage is an underestimate of the true rate of damage. Assuming all operators make a decent effort to achieve LBAP, then up to 15 to 20% of lead fixation helix could have some degree of damage. And why this matters? Because a single physical stress event could create cracks that will initiate fatigue fracture, resulting in premature conductor failure. And that has already been clinically observed. A lead model implanted LBAP has a higher failure rate than when it's implanted for right ventricular pacing. Now, many of the LBAP patients are pacing dependent, so if their lead fails suddenly without any warning, that could result in syncope or even death. I'm talking about this again. And the concern is that the failure rate will start to accelerate exponentially suddenly in the future. We only take a small number, maybe 10 to 20 of deaths attributable to lead failure, attributed or attributable to lead failure to trigger recall. Okay, delayed septal perforation will result in a loss of ventricular capture almost inevitably, so you have the same implication as for conductor fracture. But also it could result in VT. We have perforation of the left ventricular free wall and also stroke as well. So any of this scenario could have resulted in avoidable iatrogenic deaths. Could have occurred if the patient had been pacing dependent, the patient be discharged home. So think about whether you want to do same-day discharge after you've done LBAP. The patient will have a pacemaker, no, ICD. If the VFVT event occurred at home, the patient could have been gone. And the VT induced by the LBAP lead was hemodynamically unstable, or the LBAP lead had also been the defibrillator lead. Then the defibrillator may not work or may not sense at all. Or if the stroke had been permanently disabling. Now, the title, one case report on delayed lead perforation is particularly thought-provoking. It mentions causation. Causation means legal liabilities. Well, think about that. Okay, so I've talked about all the recognized complications of LBAP specific. Complications, but what about unrecognized LBAP complications? Do we know all the unrecognized complications of LBAP? Now, inside our abrasion was not a recognized mode of lead failure until it occurred in large numbers suddenly, probably almost a decade after the model was introduced. So there's a lot of uncertainties about LBAP. Okay, I'll finish talking about the complication. I'll talk about the benefits now. The benefits claimed for LBAP will include better electrical synchrony, better mechanical synchrony, reduced heart failure hospitalization, and reduced mortality. Now let's examine the evidence base for LBAP's benefits. Mostly they come from retrospective observational registries. Patient selection is a very powerful confounding factor for the result. Historical control could not be necessarily fair measures because other aspects of healthcare could have changed. Propensity matching could only adjust for known and quantified confounding factors. The observers may not be blinded, generally speaking, not blinded, and they could have been influenced by the subjective biases in assessing the patient's response. And better surrogate measures may not necessarily translate to clinical benefits. And reduced heart failure hospitalization could have multiple confounding factors. And to date, there's been no prospective study showing prolonged survival with LBAP. And BioPace is a sobering history lesson from history, so we may have enthusiasm, optimism, not living up to expectation. So if LBAP overused and oversold, I think you should decide. Thank you.
Wonderful, thank you very much. And now to give the counter argument, that left bundle branch area pacing is underused and undersold, is my great pleasure to introduce Professor Pugal B.J. Raman.
Wow. I felt like I was sitting in a Tarantino movie. And also, I thought in grade school I was good in math. And have to quote President Bush, that felt like fuzzy math to me. I'm going to argue slightly differently, showing more evidence. So we knew more than 100 years ago that pacing, if you don't do it in a synchronous fashion, well, even if you pace from LV apex or base, it's not good. That's a known information for a century. We also know pacing from the right ventricular apex or anywhere in the septum can lead to electromechanical dyssynchrony and abnormal metabolic activity, and leads to a vicious cycle of adaptive, maladaptive cardiac remodeling. And if you look at multiple series, the incidence of pacing-induced cardiomyopathy is not small. Ignoring that fact and keep doing the same mistake that we are doing also leads to some of the arguments Dr. Lau made, that you would be doing the mistake. You could be sued for not doing the right thing by preventing these complications that you could have prevented. And looking only at pacing-induced cardiomyopathy, it's looking at the tip of the iceberg. So there are lots of other issues. There are more heart failure hospitalization, atrial fibrillation, and all these things contribute to increased mortality. And look at multiple studies, whether if it's pacing-induced cardiomyopathies or pacing-induced heart failure hospitalization. That number is not small. It's up to 10 to 60%. It's almost all of our patients. So are we pacing? We shouldn't be pacing. If we use all of the risk-averse arguments, I should be leaving here and retire today. I want to present this 75-year-old man with chronic left bundle branch block, LV ejection fraction 40%, intermittent heart block, who presented for a permanent pacemaker. This was one of our early procedures. I normally do his bundle pacing. We learned some of the limitations of his bundle pacing. I could correct the left bundle branch block, and then I paced left bundle branch pacing and confirmed that I have left bundle branch capture with transition from non-selective to selective. And then I proceeded to optimize, utilize native right bundle conduction and left bundle branch pacing. The result was this is acute baseline dyssynchrony before the implant, and this is immediately after. So this is a correctable problem. Why would I not do this for all my patients if I can do it and correct a problem that can be completely corrected? Go to the base of the problem itself and produce the solution. So we've been doing that for many years, and we use any patient with AV block. This is our series of consecutive series of patients, every single patient, and majority of them are AV nodal, and the remaining were infranodal, about 48% of them. And we were able to assess that site of block to be intrahisian, and only a very small percentage of patients that we couldn't correct with this bundle pacing. And the so-called infrahisian block was about 4%. So assuming that the vast majority of patients, you can provide conduction system pacing. And in this manner, either using LV septal pacing or left bundle branch pacing, we can achieve conduction system pacing in 97% of. Why would I not do this for someone, any patient that comes to our lab? Because it's doable, and you can doable in a safe fashion. And with evidence showing that this is a series of two-center studies showing that we can reduce death or heart failure hospitalization, what more can you do to prove benefit in terms of greater than improving mortality? And this is not just two-center. Looking at the Medtronic 3830 surveillance registry, it's a FDA-approved registry that's ongoing for a long time. So the lead, we were able to assess his bundle pacing and left bundle pacing. Of course, his bundle pacing we knew and we learned. This was before left bundle branch pacing because we didn't have a better alternative. And we know that the lead-related complications for left bundle branch pacing is a lot lower than his bundle pacing. But this is just comparison within group. And the mortality benefits were similar in both groups, so suggesting that left bundle branch pacing was probably reasonably close to being as good as his bundle pacing. So what about real-world evidence? Now, my colleague pointed out that this is being overused. Yes, it's being used more. Now, this is a Medicare study, about 23,000 patients, 6,000 patients with conduction system pacing. And even at 6 months, without adjudicating, without making sure that all of these patients have conduction system capture, just the intention was there, we're able to show that there's a reduction in mortality and heart failure hospitalization. And so all the things that he was worried about, complication, lead-related reinterventions, no different from right ventricular pacing. So all the fear induced by the potential possibilities of complication shouldn't prevent you from trying to do the right thing. The intention has to be there. And of course, his bundle pacing has slightly higher risk for complication and need for reinterventions. And styler-driven leads is a larger lead. There was some concern. And even here, at 2-year follow-up with the styler-driven lead, there was reduction in mortality and heart failure hospitalization. And if you look at lead-related complication, in fact, they trended to be lower. And reinterventions also trended to be lower with left bundle branch area pacing compared to RV pacing. And similarly reproduced in a larger Milos reloaded registry that you saw, improved mortality when you have left bundle branch area pacing compared to right ventricular pacing. Yes, we need a randomized clinical trial. Early efforts have been there. These are one of 2 trials. This is C-SPACE from Australia. This is another one, PACE heart failure from Australia again. And 120 and 200 patients showing improvement in LV ejection fraction, reduction in heart failure hospitalization, and mortality. So we have clear signal. We do need large randomized trial, and I want to congratulate our chair for starting this clinical trial, Protect Heart Failure, RV pacing versus conduction system pacing. And he's reached the goal of recruiting patients quite early, 2,600 patients already reached, and he's going to continue to enroll and probably give us an early answer soon. And complications and extraction issues were discussed about. So these are patients with left bundle branch area pacing removal. In fact, I find, especially with the 3830 lead, removal at 1 year, 2 years, and this one was even at 6 years, the lead could be removed rather easily, much more easier than traditional right ventricular pacing, at least so far. We need to see long-term data to see that if it can be done. And so, in the other part is that in conduction system pacing, we were able to extract them with just manual traction, 90% of them. Some of them are shorter duration, but mechanical tools worked. And the success of extraction of all of these leads were 100%. So we need to be diligent. We need to continue to do this. And also lead-related complication. We have to learn and why these leads fail and what is the reason for it. And we have to correct the course. And I think the manufacturers are coming up with better leads, and that would avoid this. And they are doing very diligent testing on left bundle branch area pacing location. Can we avoid future problems? So what is the prediction for 10-year survival for these leads? All these are happening at this point. And this was a Medtronic CareLink data previously published, and that showed the RV pacing still huge amount of RV pacing. That hurts to see. We're still causing all those injuries and heart failure hospitalization and mortality and all of those that could be prevented So we could be sued for not doing what we think we should be doing. And thankfully, that is changing. And the trend, at least from what I know, is that in the CareLink data right now, it's more than 50% of the implants are 3830 leads, suggesting people are attempting conduction system pacing at this point. And now we have leadless pacing, and we heard yesterday about leadless CSP, possibility that we can combine both. We have best of both worlds and improve outcomes. And yes, it's being oversold. There are 1 million 3830 leads implanted now, and these are just a sign of how much conduction system pacing has been adopted. If so many of us are adopting and not seeing the adverse events and seeing the possible benefits, then there must be some truth to it. And we do have tools, multiple tools, to facilitate, improve, and we will get better, and education has to happen. Most of us will get better in improving. And I just want to finish the horror show. Transvenous pacemaker, the traditional right ventricular pacemaker, were not without complications. We still continue to have complications, and you can still cause perforation. This is an example of RV lead perforating RV, LV, and even into the lungs. So you can do it with any leads. Tricuspid regurgitation, we saw earlier that it's no different in leadless pacemaker versus transvenous leads. So it's an unfair argument that conduction system pacing is going to cause more tricuspid regurgitation. And leadless pacemaker also have complication, and they are not small. Perforation, as our previous speaker pointed out, some of them can be quite dangerous, needing surgical interventions. So to conclude, I want to say that left bundle branch area pacing uptake has been slow, but much faster than his bundle pacing because people recognize that this is a much better and easier option than his bundle pacing and probably provides better benefits than traditional right ventricular pacing. I feel like there's no reason to perform right ventricular pacing in any patient unless there's strong reason for leadless pacing and not leadless conduction system pacing. The incidence of pacing-induced cardiomyopathy, I can boldly, proudly say that in our center in the last 10 years is less than 0.5%. We don't see it. It's gone. It's disappeared from our practice. We have 9 electrophysiologists, and none of our surgeons or general cardiologists implant pacemakers because they handed it over to us because they recognize that we can do better, and no pacing-induced cardiomyopathy. So if you see a pacing-induced cardiomyopathy, that's an opportunity missed that could have been prevented, because going and re-intervening to treat that is a lot more challenging than preventing it in the first place. We will have improvement in tools, and we will have imaging guidance to be precise and get to where we need to go. And it is possible to achieve conduction system pacing in 100% of the patients attempted. And with that, I'll stop. Thank you very much.
So thank you very much. And if we have questions from the audience, please come forwards to the microphone and add to the debate. So 2 very strong, powerful viewpoints. So Dr. Lau, what do you think, what will shift, what do you need to shift the dial in your conversations with patients? What evidence will change your mind?
I'd like the procedure to be more consistent, more reliable, more predictable. But at the moment, I don't think it is so. And the uncertainty aspect is actually very disconcerting for me. I know when I'm going for LV or LBAP, I want to know that I'm not going to get LV septal pacing.
Okay, so that's a very...
Yes, it's a simple thing.
Yep, that's
I'm not going to have failure. I don't want to go through the entirety of suffering the risk without any benefits.
So that's a very fair point, Pugal. So they've been able to consistently deliver what we set out to do. And I think that's a fair point. What we're seeing in the real world is that not all patients are getting conduction system capture, maybe in your hands and very experienced hands, but what do we do about that?
Yeah, that shouldn't stop us from trying, number one. Number two, I just want to make this clear. In bradycardia patients, and as we saw, that's a real-world data, and that's from, I think, 75 to 100 centers. and clearly shows that left bundle branch area pacing leads to better outcome than what we are doing with current right ventricular pacing. Yes, we should get better. Don't extrapolate this to cardiac resynchronization therapy as a fair warning. But it is doable, and we were not good with biventricular pacing for a decade. Now we know what is the best option for biventricular pacing. You place the lead in a good location, ignore the apical position, ignore region with scar. And so we know how to avoid that. So the same level of education has to be provided, training has to be provided. We can teach someone to put a 27 French sheath either from the groin or from the neck, place a leadless pacing, but we cannot teach electrophysiologists to follow physiology. That's doable. I think we should go back to paying attention to electrophysiology. Assessing left ventricular septal pacing or left bundle branch pacing is not that challenging. We can. In the vast majority of patients, it is very easy, straightforward, simple. Don't fall for surrogate markers. We can clearly identify them. And we do need better tools, better guidance, and I think it's coming.
Well, I think it's great to hear that we're putting the physiology back into electrophysiology, and I think this is just an exciting time for pacing, which hasn't been exciting until recent times. So congratulations to you both. I think that techniques are improving, tools are improving. I think this makes us all think a little more closely about lead manufacturing and structure, because you are right about some of these intra-electrode fractures. They're not common, but they occur. And I think it behooves us also to say, when you have this risk-benefit discussion with patients, and Judy, you brought this up nicely in your talk, and the risk-benefit profile changes across the lifespan of the patient. And I think we have to think about that as well. But, the hope and the attempt to make physiology better should be energizing for all of us. And on that side, leadless pacing, we heard from the presentations yesterday that technology is improving as well, and they clearly see the need to target conduction systems. So I think, stay tuned, come back next year, because there will likely be more and more exponential breakthroughs and improvements. So.
Yeah. Thank you. Just to counter that a little bit, we do obviously need to think about, we talked a lot about the data, but a lot of our data is observational, and the criticisms about observational data are fair. There can be selection of patients. So I think there is a need for randomized data, prospectively collected, and sometimes what we think is best turns out not necessarily to be true. So we do still have, there still are unanswered questions in this area.
Absolutely, I agree. I was not aware of the Journal of Risk and Uncertainty as a journal, so thank you for that little point. That was useful math. But yes, I think the randomized controlled trials has been our gold standard. We are driven by evidence-based medicine. I personally think that these trials need to also have ECG adjudication to avoid septal pacing. There is a recurrent signal from last year's meeting and this year's meeting that septal pacing can be deleterious for patients. So again, understanding that physiology and doing that is important for us to do. So we're super excited to hear your results. Will it be a late breaker next year?
Well, our trial not, because this is a long term. So we're the primary endpoint is heart failure, hospitalization, and death. So
over what time? What's your time follow-up?
Well, you need enough time. We need enough events to have occurred.
So it's an event-driven.
Well, yes, likely to be, if we can convince the funder. So this is always the difficulty, is that funders like to know when the trial is going to finish, but actually, if you've not had enough events, then even though the treatment may be better in the long term, you don't detect it. So we're trying to convince them to allow us to do event-driven analysis. There's just, I think, time for one question on the panel from the iPad. Is regarding the more complicated scenario, as you point out, Pugal, in terms of the CRT population. What's your opinion regarding sort of lot versus bi-B pacing in that group. So should we be going for 2 leaded systems first of all, or do you think all patients should get a lot? What's your approach?
So, so biventricular pacing is a great therapy. The bar is set high, and when we do left bundle branch pacing in left bundle branch block, so the clear answer is when you have proximal left bundle branch capture, you have complete correction, then you know that that's the best you could do, irrespective of whether you're going to do bi-V or conduction system pacing. But you need to strive to achieve that. If you don't achieve that, then right now we don't know if it's good enough. So for that purpose, I think we should continue to do biventricular pacing. But the reverse of the question is, can we do both? And that's a possibility. I think it's a possibility now that the ICD leads are available, but we're also not sure, can we consistently and safely place the ICD leads in a proximal left bundle branch pacing location. We can place it in a deep septal location. That both the LEADER trial as well as the ASCEND trial had shown. But can we place it in a place that would provide us the additional benefit? We don't know that yet. So.
Great. Well, if there are no further questions, we'll conclude that session. Thank you very much. 2 excellent talks. And we'll leave the audience to decide what they do going forward.
Okay.